All right, so my name is Pete Pickering. This class is called Intro to Event Management for ALS providers. I think this is going to be a class that's going to be really useful for a lot of people. I know here in this county you guys have event, and when you do event transports, it's a paramedic from this agency that actually manages the event. So for you, this is extremely relevant, but I really feel like this is relevant for all ALS providers that do interfacility transport, because if you do interfacility transport, at some point you're going to end up doing event transports. And even if you've got an RT or somebody else managing the event, we need to be able to have intelligent conversations with them about the settings, about the patient, and when changes are necessary, we need to know what's going on so we can document that appropriately at the very least. So the objectives for this class are going to be to try to provide everybody involved with terminology that they can use to discuss the issues that are relevant to patients that are being mechanically ventilated. And on top of that, to be able to understand where the calculations come from for different vent settings and how to adjust those, when to adjust those, and how to record appropriate patient responses to that, as well as understanding the different vent settings, or the vent modes, and different vent strategies. I know we've got just two people here. Some have experience on vent, and then others not. So that's the thing about with ALS transport. For a lot of people, this is a first encounter. This information is going to be your first exposure, and some of it's a little bit complicated. If you don't get it all on first exposure, you're not supposed to. I didn't. So this is something that we're going to practice. So we're going to go through all of the different points that we want to talk about, and then we're going to practice a little bit right here, and just expect that repeated practice and repeated review is where you're going to really get comfortable with this stuff. But if you have any questions as we go through it, just let me know. All right, the first thing that we're going to go through is going to be just some basic terminology regarding the underlying anatomy and physiology of ventilation and respiration. Then we'll get into the mechanical vent stuff itself. Any questions? Okay. All right, so the first thing I want to talk about is the differentiation between ventilation and oxygenation. So ventilation, of course, is just moving air in and out. That takes place in the airway and in the lungs, and it's just if you're moving air in and you're moving air out, then you're appropriately ventilating, whether or not oxygen is getting to the cells. Oxygenation has to do with the passage of gases, carbon dioxide and oxygen, both across the alveolar membrane and as well as across the cellular membrane. So that's occurring systemically, right? And that's how we're going to analyze our patients and evaluate them for dysfunction, is analyzing separately ventilation versus oxygenation. So the next thing I want to talk about is VQ mismatch. That's a term that people have heard a lot, but it's not very often explained. And VQ mismatch is just basically any situation where there is a difference between the effectiveness of oxygenation versus effectiveness of ventilation. Okay, so V stands for ventilation. The Q, and I'm not sure why they come up with the letter Q, but basically it's cardiac output. It's perfusion and circulation. And the way it's actually quantified is going to be, like I said, cardiac output. So ventilation is going to be measured by minute volume. That's the entire volume of air that you're breathing in and out over the course of a minute. So if you've got a minute volume that's high and a cardiac output that's low, then that's a VQ mismatch. Same thing if it's reversed, right? So obviously a VQ mismatch can move in either direction, so there's a different name for each of the two types of VQ mismatch. The first one's going to be a shunt, and a shunt is going to be a situation where the alveoli are being perfused with blood as normal, but the alveoli are not moving gas across into the blood the way they should. And that can happen for a number of different reasons. If you're in a low oxygen environment, you're going to have a shunt. If you have an obstructed airway, whether it's obstructed by a foreign body or it's bronchospasm, like in the case of COPD, then you're going to have a shunt. They're having difficulty ventilating. They're not having difficulty oxygenating with the oxygen that gets in. That makes sense? Okay, so then the other one is going to be a dead space VQ mismatch. If you've got dead space mismatch, just the opposite is happening. So you're moving air in and out, no problem, but you are either not passing gas across the alveolar membrane for some reason, or you're not getting adequate blood to the alveolar membrane in the first place. So that's examples of that are going to be like a PE That's going to be the most obvious example. You are literally not getting blood to the alveoli because there's obstruction there. But it could also be CHF, just low cardiac output, cardiogenic shock. You're not getting blood to the alveoli. But it can also be caused by damage to the alveoli themselves. If you've got, for instance, ARDS, which we'll talk about a lot here in a minute, ARDS results in multiple symptoms, but one of them is going to be buildup of mucus in the alveoli themselves. So you can move air in and out of the alveoli fine, but you're not getting gas exchange there. Does that make sense? All right. So those are two different kinds of EQ mismatches. We're not going to spend a whole lot of time like naming and labeling, but we do want to concentrate on the concepts, because once we start talking about the vent settings and we have a patient who's not responding well to the vent settings we've got, we need to analyze, well, which side is the problem on? What's the list of things that could be causing that problem? We go down the list and we rule things out until we find the problem, right? It's like we would do with anything else. With that, I'm going to skip over oxyhemoglobin dissociation curve right now just for the sake of time. It's not necessary to understanding the rest of what we're going to talk about, but it is an interesting topic. If you want to, we can talk about it afterwards, and I've got some resources that I'll talk about at the end, including some that really go into great detail about the oxyhemoglobin dissociation curve and how that affects ventilation and oxygenation. Anyway, I'm also not going to go over the gas laws. Those are really more for flight, transport. They're not really relevant if you're not making major changes in pressure like you would when you're at altitude. All right, so the next thing I want to talk about, and this is probably the most important thing that I'll talk about, if you forget all the numbers and calculations and everything else, those are all resources you can write down, you can keep notes on, you can look up later. But what we're going to talk about right now is going to be the risks that are posed by mechanically ventilating a patient, both immediate and long-term, because this entire talk, the entire process of learning vent settings is really about preventing those issues. Give that a second.
There he is.
All right. We might have a few interruptions like that, and I apologize. So yeah, we're going to talk about some of the issues that can come up with ventilated patients, right? So the first one I want to talk about is ARDS. We've already mentioned it. That's going to be something that I'm going to mention over and over and over again, because so much of what we're doing when we're evaluating patients who are on vents, when we are coming up with vent settings, is going to be about preventing ARDS. ARDS is a huge risk to a patient who is on a mechanical ventilator. The number of patients who are put on mechanical vents and end up with ARDS is actually on the decrease right now, but it's still a very, very large percentage because as soon as you put somebody on the vent and you start ventilating them with positive pressure instead of negative pressure, it puts in stress on the lungs. And that's ultimately what ARDS is just an inflammatory response by the lungs that's caused by them being stressed out. All right, so there's two things that we do when we put somebody on a vent that puts them at risk for ARDS. One would be over-oxygenation, and the other is overinflation, repeated overinflation, or extended over-oxygenation. Right, so if somebody's oxygen gets a little too high for a few minutes, that's not an emergency, but the problem is we tend to over-oxygenate people for extended periods of time. So I'll talk about them both individually. If you over-oxygenate somebody, the route that takes them to ARDS, to that inflammatory response, has to do with what happens to the excess oxygen in the blood. So know that when hemoglobin gets saturated with oxygen and you're at 100% SpO2, you keep adding more oxygen, the extra oxygen just dissolves into the blood. It literally just gas dissolves into the blood itself. While it's in the blood, it's free and available to combine with other chemicals that are in the blood. When oxygen starts to combine with chemicals that it's not supposed to combine with, all kinds of chemicals, hormones, things like that that are in your blood that have important jobs to do become free radicals. And free radicals are just the names of different kinds of chemicals that are not supposed to be in your bloodstream. Again, they form when chemicals that are supposed to be there combine with oxygen. Those can form cancer in the long term. when you're talking about a chronic state, but acutely and over a shorter period of time, they cause inflammation, and it mainly causes inflammation to soft tissues. So the liver is going to be very, very susceptible, and the lungs are going to be very, very susceptible to inflammation when you've got a lot of free radicals in the blood. So for that reason, we want to keep their oxygen at a reasonable level. All right, and we'll talk about blood gases here as soon as we get through some of these issues. If you want to keep track of whether or not you're over-oxygenating somebody, you have to have recent blood gas results. Otherwise, you don't know. SpO2 tells you how much hemoglobin is saturated with oxygen. It tells you nothing about whether or not there's extra oxygen running around in the blood. So if you've got somebody who's at 88% oxygen SpO2, then I don't see how they could possibly have extra oxygen running around their blood. It's going to start to be absorbed by hemoglobin. But when you've got these people and all you see is they're 98, 99, 100%, you have no idea whether or not they're over-oxygenated. So we need a blood gas to find that out. The other way that you're going to end up with ARDS because of mechanical ventilation is going to be because of, like I said, extended overinflation or repeated overinflation. And what's happening there is there's nothing chemical, nothing fancy going on. You're just stretching the lungs out and they're getting tired of it. So what happens is with ARDS, with either route, is that the lung starts to lose compliance because the lung tissue actually starts to stiffen. Just think about any other tissue you've got when it's inflamed from an injury, whether it's muscles or a cut or something like that. Think about how thick and tough that tissue gets. So you decrease lung compliance. The other thing that happens, and we've already mentioned, is mucus starts to build up in the alveoli because of the inflammation, and so you start to add to dead space, and you start to decrease the surface area that you have available to exchange gases. So obviously that's not good. What do you think you can do for somebody who's got ARDS? You've got somebody who's already on a vent, and they've developed ARDS. What do you think you could do? They've now got a shunt. They've got a VQ mismatch.
You have to correct whatever's going on that's causing the mismatch, whether it be over-oxygenation or...
Right. You're right. So you deal with the underlying cause, but the problem is their SpO2 is dropping now. They're having a hard time oxygenating because they've got this increased, I said shunt, this is actually going to be dead space. Because
lower pressure and increased time.
You lower pressure, you increase time is going to how you, is going to be the accurate way to correct this. And that's treating the underlying problem. Traditionally, what they did with ARDS was, as you increase this dead space, well, now this person needs even more oxygen, right? We're seeing SpO2 drop. They've decreased their available surface area for gas exchange, so we need to get more pressure, more oxygen in there, and so effectively trying to treat this patient for their acute hypoxia was making the underlying cause, the ARDS, much, much worse. So yeah, where we've ended up is that's just a snowball effect. We've got to avoid that. We've got to stay away from it. So ARDS patients, they call baby breathers. You want to go with a high rate and a low volume, and you want to get the FiO2, which is the amount of oxygen that we're actually giving them, as low as they'll tolerate it. Okay. And we'll talk about some things you can do to try to increase the patient's ability to receive oxygen without actually giving them more oxygen. And there are some things that we can do.
So would we be better off when we transport these patients, or just in general, would you be better off to keep their saturations lower?
You don't want to keep the SpO2 low. That's why I say you have to have a blood gas. You want to keep the FiO2 or the PaO2 within normal range. And I'll put up blood gases here in just a second to show you the normal ranges. But it's going to be between 70 and 100 centimeters of water is going to be where you want to keep it. So if you don't have a recent blood gas, then you're still going to try to keep their SpO2 above a certain level, just like you would with any other patient. So get that recent blood gas, and if you see that the blood gas is showing that the PaO2 is too high, then you need to cut back on FiO2. You're not going to be able to recheck blood gases en route as a transport provider. So what you're doing there is coming down as much as you can on FiO2, moving slowly in small increments. We'll move everything slowly in small increments, measuring response as we go. and you're just going to have a limit on SpO2. So you can keep coming down on FiO2 until you get to a point where SpO2 starts to drop, and that's where you have to cut it off. So that's where using SpO2 as a diagnostic is going to be a tool, but you're not trying to bring it down. When SpO2 starts to drop, you've hit the limit.
Yeah.
Does that make sense? Okay. So I'm going to go ahead and move on from ARDS unless anybody has any question about ARDS. Good on that. All right, so the next thing that I'd like to talk about is acute lung injury. That's going to work right with ARDS. Preventing ARDS is going to prevent ALI. Acute lung injury is going to be the short-term damage or the immediate damage caused by overinflation. So that's not you're overinflating a little bit too much for a long time. That's you're inflating way too much and you just cause barotrauma. And we're familiar with that. We talk about that all the time when we're doing our ACLS. We're talking about running codes and not overventilating. And there we're not doing calculations and having exact tidal volumes, but we still know, squeeze gently, titrate to chest rise. We're not trying to overinflate the chest. That's the same thing. Another issue that you're going to have to deal with, and we won't have to deal with that as much as ALS transporters, but it's going to be trying to prevent ventilator dependence. Right, so you know that when people go on a vent for any reason, even if it's just for a surgery, they're expected to be taken off the vent within a short period of time. The longer a person spends on the vent, the more dependent their body becomes to the vent, and the longer it's going to take to wean them off. And we've already mentioned it, but the biggest difference between the ventilated mechanical ventilations and a patient's own natural ventilations is going to be the difference between positive pressure and negative pressure. As your body gets used to getting every single breath by positive pressure coming from external environment, your diaphragm stops working, right? It takes a vacation, says, oh, I don't need to keep doing this. So you start to train yourself not to breathe for yourself, and the longer you do that, the harder it is to come off, right? So when you're getting a patient from the ED and they are completely sedated and completely paralyzed, we are not doing anything to let them breathe for themselves. So we're not doing anything to work towards independence again, right? They're completely dependent at that time. That's normal. That's okay. They just got put on the vent, and they've got put on the vent for a reason. And until we get that acute issue solved, we're not worried about weaning them off the vent, right? When you're getting a patient off the floor who may have been intubated for several days, you may be picking up a patient who is in the process of being weaned off, and they may be in a different vent mode that allows them to take breaths for themselves, and they may not be on any paralytics. And that's when vent dependence and trying to prevent vent dependence is going to be a big issue, and that's going to be about choosing the right vent setting, the right vent mode that allows them to breathe for themselves. And when you've got a patient who is allowed to breathe for themselves, in addition to getting ventilator-initiated respirations or ventilations, it brings up a whole new host of issues that we need to look at, like air trapping and breath stacking. We'll get to that again once we get into the different settings. Another one's going to be hypoxic drive. I don't think we need to talk about that too much because as ALS providers, we've talked about that a lot. You don't have to have a COPD patient on a vent to be worried about hypoxic drive, and we know that that's not something that's going to happen in the 10 or 15 minute transport to the ED, but with a patient who's on a vent and they're looking at more long-term care, any patient with COPD that we're taking on interfacility transport, we need to be very careful about over-oxygenation there, right, because we don't want to kick in hypoxic drive. There's another one you'll see on the sheet, and it's got kind of a technical sounding name, but absorptive atelectasis. That one is a little bit technical, but I just threw it in there because it's pretty cool. So atelectasis, what's atelectasis? It's a fancy term. Right, it says collapsed alveoli. So we're familiar with that with our emphysema patients because we know end-stage emphysema, that's what's happening. They're having more and more atelectasis, more and more alveoli are collapsing. With absorptive atelectasis, what's going on is that you're losing your natural PEEP. With emphysema, you're losing your surfactant, right? So the inside surfaces of the alveoli stick to themselves. This is a completely different process. When you think about the composition of the air that we breathe, you know that oxygen is not the most prevalent gas in the atmosphere, right? It's about 21%. What's the most common? Nitrogen, right? And it's also heavy. It's a larger, heavier molecule that does not pass across the alveolar membrane into the capillary bed, right? So when I inhale ambient air and oxygen starts to be absorbed into the bloodstream, the carbon dioxide, the nitrogen, things like that, they stay there. And as I'm getting ready to exhale and carbon dioxide is starting to be absorbed into the alveoli from the blood, and then I exhale that, the one constant that's there in your lungs is this baseline level of nitrogen. When you start to over-oxygenate somebody, another thing that can happen, and it's a little bit more rare, but you over-oxygenate somebody too much, and the oxygen that you're forcing in starts to displace the nitrogen. Does that make sense? Every time you exhale, you're exhaling some of that nitrogen, but you're on 100% FiO2, you're not breathing any more in. So now, before too long, all of the gas that's in your lungs is pretty much pure oxygen, and all of that can absorb across the membrane, and so you're literally losing the gas that's keeping your alveoli inflated, and so they can start to collapse. It's just another possibility when you're over-oxygenate somebody. It's a little bit more acute than hypoxic drive or ARDS. So it's something else to look out for. Another one's going to be air trapping. I know I already mentioned this, but I want to explain it because this is going to be a big one. This is the one that's going to be on the opposite end of the spectrum from ARDS and ALI. When we're making vent setting calculations, we are on a balancing act between trying not to overinflate, but also trying not to ventilate at a rate that's so fast that they're not able to fully exhale. If they're not fully able to exhale, then our patients are going to start building up that carbon dioxide rich, oxygen poor gas in the distal reaches of their airway in the alveoli, which is going to create more dead space, right? And then you end up with the dead space mismatch again, because you've got increased amount of lung space that's not able to make gas exchange, and it's not able to make gas exchange just because you filled it up with gas that is already high in carbon dioxide, so it can't receive any carbon dioxide. It's low in oxygen, so it can't give any oxygen. So that is, again, an acute issue that's going to happen right now if your rate is too fast or if your E time is too low. And once we get to vent settings, we'll talk a little bit more about how to avoid that. But the short version is going to be with ARDS, with preventing injury, preventing ARDS. We're going to try to go with a high rate, low volume, or low pressure. With someone who's got issues with obstruction and is having a hard time exhaling, we need to give them a little bit lower rate, a little bit higher volume, knowing that that does risk ARDS, but the more immediate risk is going to be that we cause air trapping. We have to make sure that they're able to fully exhale. Does that make sense? All right. We'll skip over 8A gradient for right now, and we're going to get into some of our terminology for the vents themselves. So I'm going to start with, and I know we'll get right into tidal volume and stuff there, but first, just so we have it kind of up here on the board, in the background, I want to talk about your ABG, your blood gases, and what those values should be. So every blood gas is going to include four things. It's going to include a pH, it's going to include a PCO2 or PaCO2, it's going to include PO2 or PaO2, and it's going to include your bicarb. Actually, I'm just going to write bicarb because I don't want to mess it up. All right, so your normal pH range. Right. And your normal PCO2, your normal partial pressure of carbon. What's that? For carbon dioxide.
35 to 45.
35 to 45, right? And that's measured in centimeters of water. But it's the same numbers that we get for our EtCO2 normal range, right? So that's easy to remember. How about the PO2 or PaO2? Yeah, and it can actually go lower than that. Like in one text I was reading, it was 70 to 100. It doesn't have to be super high if you're maintaining adequate SpO2 and you're seeing your PaO2s in the 70s, that's okay. But it's going to depend on the patient and what kind of patient. Watauga Medical Center, I know when they do theirs on the actual sheet that prints out with that lists it, their normal range is 80 to 100. So the range is going to vary a little bit, but you can definitely get down below 90 potentially, depending on what kind of patient it is. Some patients you're going to need to keep them. You're going to have a higher goal depending on what's going on with the patient. But I'm going to go ahead and just give the largest range that I saw, which was 70 to 100. And then bicarb, I'm just going to put this up there. Normal is about 24, and the range, it doesn't have much of a range. Maybe you might see a range of 20, yeah, 22, 26, 20, 26, something like that. But we're not going to talk much about bicarb today because we're talking about vent patients. Bicarb is really kind of an indication of the metabolic side of the acid-base balance. The more you know about acid-base balance, the more you know about lab values, the easier the vent stuff is. And I really encourage everybody to dig deeper into that stuff when you get vent transport or any kind of transport. If you've got time, you know, it seems like the popular thing to do is you've got a patient who's really stable. They're just basically taking a nap on the way down. I'm going to bang out my report and keep an eye on the patient, of course. But if you've got time to do a little extra, make sure to make time to dig through that report and look and see what lab values were. Look at some of the doctor's notes. You'll learn a lot. And you'll get a really good idea of what's really going on with the patient because you'll learn a lot more from that than you will from any oral report that you get. Because you just get time to dig a little bit deeper and research if you need to. So those are your blood gases. The next thing we're going to get into is going to be your specific vent terminology. So we'll start off with tidal volume. Put these in a different color. So tidal volume is going to be written as VT, okay? And you can see it's on those sheets. Tidal volume is VT. Tidal volume, normal range for tidal volume, and this is something that you both read on the vent, and if you're in volume control, it's also something that you can actually plug in. It's going to be an actual setting. And what you're going to use to figure that is going to be 4 milliliters per kilogram to 10 milliliters per kilogram. And anytime we're talking about vent settings, when we talk about patient's weight, we're talking about their ideal body weight. Okay. If you look at the handout I showed you, I think it's on the 4th page. Yeah, you'll see that there's a chart there for ideal body weight. Also, I know that you guys, with the vent itself, yep, you've got a laminated chart that shows you, I think it might not have the exact same numbers, but they're going to be very, very close. It's going to show you ideal body weight. There's also a calculation you can use, and this is going to yield lower numbers than the chart will, and it's because they want you to be conservative with your tidal volume. But they're also going to cause you to be conservative, if that's the right word. Low is probably a better word with your minute volumes. But if you're just looking for a quick guesstimate, the way to do it is start with 5 foot and 50 kilograms, and for every inch above 5 foot, add 2 kilograms. So a 6 foot person would be 24 plus 50, right? So 74. And if you look it up, I think you're actually going to be closer to 80 on these charts for a 6 foot person, but it's kind of a ballpark. I think you're a lot better off if you actually use a chart, something that's established and that you can basically pawn some of the liability off to. You're using a chart. This chart is been approved, so it's not on you, right? Once you've determined ideal body weight, yeah, this is the range for tidal volume, right? So what would you think would lead me to lean more to one side of the scale or the other? With what we've already talked about with ARDS and air trapping.
The person's size.
Well, this is actually going to be a goal for whether I'm trying to make it easier for the person to exhale or easier on the lungs by not overinflating them. If I go with a low end, it's going to yield a lower pressure because it's a lower tidal volume, right? Does that make sense? So I'm not expanding the lungs as much. I'm being easier on the lungs, and I'm protecting them from injury. But Over here at the high end, I'm going to have a much slower rate, obviously, because I'm giving much higher volume. So I'm giving the person plenty of time to exhale. Don't ever start anybody on a vent at 4 or at 10, or at least not in normal circumstances, because it gives you no room to move one way or the other. So for that typical patient that we're just trying to prevent injury on, we're going to err more to the low side. So one of the books that I read, and the one that I get this recommendation from, they gave the number 6 as a good starting place for most patients to prevent ARDS. And then if you've got a COPD patient and you're trying to err on the other side, you're going to start around 8. Okay, but you've got that range. So within this range of 4 to 10 that you can move around in, for a starting point, you want to start somewhere between 6 and 8. So that's nice and narrow, right? So just real quick before we move on to the next one, you have a calculator on you? Let's just I'll throw a patient's height out there, use that chart, and you'll have to know male or female. So if I give you a female who's 5'7", let's figure, and we want to start her at 6 milliliters per kilogram of ideal body weight.
Okay,
What would our tidal volume be?
You said 5'7".
5'7".
Female.
Yep.
You said how much?
Well, first of all, what is her ideal body weight?
Her ideal body weight's 135 pounds.
And in kilograms?
Be 61.2.
61.2 kilograms. Okay. So if I know that I want to start at 6 milligrams per kilogram of ideal body weight, I would multiply that by 6, right?
Yeah.
So what are you going to get there?
367.
367. Okay. I'm not going to write that up right now. I just wanted to practice one. So, it's easier to remember calculations once you're done.
Yeah.
And we'll do more for sure. So the next thing I want to talk about is going to be minute volume. This is tidal volume is kind of an important concept to get before you move to minute volume. But when you get a patient and you figure out and you ask for their height and figure out their ideal body weight, the first thing you want to do is figure out minute volume. And that's going to be abbreviated VTE for some reason. Yep. All right, so that's going to equal, for your healthy patient who's walking around breathing on their own, that's going to typically be about 60 milliliters per kilogram. Okay? As soon as we mechanically ventilate somebody and we hook them up to this big circuit here, we're increasing dead space substantially. So we need to actually double this number. Okay? So for the patients we're talking about, patients who are on mechanical ventilation, they're at 120 milliliters per kilogram. So real quick for that same person, 61.2, right?
Yep.
So 61.2 times 120.
7,344.
Yeah. I am going to write that one down. Oops. 44. Okay. So almost 7.5 liters a minute.
Yeah.
Is what they need to be breathing. All right, the reason we figured this up first is because once you figured minute volume, that doesn't change. We talk about moving, changing the tidal volume as needed, depending on the patient's presentation, and we'll get into why as we move through this. But minute volume for the vast majority of patients, that's not going to change. The only way you're going to change minute volume is if you have clinical signs that show you that you didn't have the minute volume right in the first place. And the clinical signs of that are going to be that you're not adequately oxygenating the patient with no other problems going on that would prevent you from oxygenating them. And if that's the case, then you're also going to see changes in EtCO2, right? What happens if you're not breathing out enough in general? If your minute volume is too low, you're just not adequately ventilating, you start to build CO2, right? You're going to see CO2 go way up. So that's hypoventilation. If you're hyperventilating, what happens to EtCO2? Drops. So there are clinical signs that can show us that our minute volume was just way off to begin with, and then we might conceivably have to change that. But once you've accurately established a minute volume, you do not change it. If you change the tidal volume, you have to make a change to rate so that minute volume stays the same, and vice versa. Okay, so there's our minute volume number. It doesn't change. We'll talk more about that in just a second, but first we need to talk about RR, which is respiratory rate. Sometimes you also see that abbreviated as a small f, which stands for frequency. And we all know that that range is going to be 10 to 20 for most people, right?
Yeah.
All right, so with that patient that we talked about first, 5'7", female. So she's got an ideal body weight of 61.2 kilograms. Her minute volume is 73.44. When you actually go to put settings in on the vent, you don't set minute volume, but you do set volume, tidal volume, and rate. And you either set tidal volume directly by plugging in a number for tidal volume, or you set it by establishing a pressure, and that pressure yields a given tidal volume. But either way, we are setting tidal volume one way or another, and we're setting rate. So we already said that for most patients, we're trying to avoid injury more than anything else, so we're going to err on the low side and start with 6. So that gave us somewhere around 360, 370, wasn't it?
Yeah.
Yeah, and that's automatically going to give us a rate of 20. Because the thing to remember about minute volume here is that minute volume equals RR times VT, right? It always will. So if I know what rate I'm shooting for, I can just divide this by my rate. That's going to give me my tidal volume. If I want to do this calculation and figure out my tidal volume, and I want to know what rate it gives me, divide my minute volume by my tidal volume, it gives me rate. There's different ways to calculate it, but it's all the same. This times this is always going to yield that. So, like I said, the book that I read that was really big about preventing ARDS and made a lot of references to ARDS.net, which is the big study that has really kind of changed the way people view vent settings. They gave us a number of 6 as a starting point. What is 120 divided by 6? Okay, 120 divided by 6 is going to be 20, right?
Yeah.
So if you're starting with 6 milliliters per kilogram of ideal body weight, if that's the calculation you make, you are always, always, always going to end up with a rate of 20, right?
Yeah.
Just stands to reason. When you go in and you actually get a vent patient, how often are they being ventilated at 20 breaths per minute? Not very often. And that's okay. We're going to talk about pressures next here in just a few minutes. As long as you're keeping pressures within the right range, that's okay. But for our calculations, that's just giving us a frame of reference and a starting point. 6 milliliters per kilogram, that's going to be about 20 breaths per minute, right? If you go in there and they're on 16 or they're on 18 and their pressures are good, then that's great. If they're on 12 or 14 breaths per minute and their pressures are near the limit of what you want to set, that's worth a conversation with the physician, with the RT, with whoever it is, to ask them why they have those settings. They obviously have much higher levels of education with this than we are. This is just intro for us to be able to have this conversation with them, but we still want to be patient advocates, and we still want to learn ourselves. We want to always be learning. So that's a place to start. I've read or I've heard, we've done these classes about ARDS. Why did we go with this particular rate? Maybe patients got a history of COPD, or they were air trapping and we had to slow it down. Whatever, there may be very good reason, but we want to know what that is. We want to have that conversation. We can't even have that conversation if we don't first know how to come up with some numbers that we expect to see on our own. Okay. And again, since we can do this backwards or forwards, we can work from tidal volume more from rate. Let's take a rate that you do expect to see coming out of the ED and figure out what kind of tidal volume they need at. So for this 5'7" female, if they're at 16 breaths per minute, what do we think should be the tidal volume? So we would just take this and divide by 16. Let's see what that comes up with. I think it's going to be about 450, 459.
459.
Right. So, and you can't set 459 in there, so we'll say about 450. So for our 5'7" patient here, if we come in and she's got an RR of 16, we would hope to see a tidal volume of about 450. And if we don't, again, we've got questions. What minute volume did you calculate for this patient? I calculated it at 73.44. So I was expecting to see tidal volumes of about 450. What were you guys working with? What were you figuring? Again, we're not trying to get into an argument with hospital staff. We're trying to figure out what's going on with this patient and why they've come up with this particular treatment plan. And we're trying to all get together on the same page, right? And we can't do that. We don't have the starting point. This is my starting point. So for me, as soon as I find out I've got a vent patient, there's two things I want to know before I get off the phone and start heading towards the hospital. Of course, they're going to give you, hopefully, what's wrong with the patient, why they were intubated, where they're going, that kind of thing. I'm going to want to know the patient's gender, height, and I'm going to want to know when the most recent blood gas was drawn, because we need to have a recent one. Okay?
You say recent, how recent? Like
within the last hour.
Okay.
For me, within the last hour, by the time when I get there, it needs to be within the last hour.
The last time we went, before I changed them off of their vent, I had them draw blood gas, and the time that they were doing the blood gas in the lab, I put them on my vent and made sure they maintained.
Yeah.
That's how I done it.
That's
I just asked them for another blood gas.
Yeah.
They fine.
And that's what, if we can get them to do it right then and there, that's ideal. So we know we can get to the receiving facility and say, when we left, this was the blood gas. They can draw another one and they can see how the patient responded to vent settings in transport, which we aren't really able to do. So the more recent, the better, but I would say a minimum of within the last hour. Another variable there is going to be, when was the patient intubated? Were they intubating the patient while they called us to come over? This is a critical patient, come on, we've got the paperwork, they're intubating now. Hopefully they got blood gases before. They should. Just about any hospital, that should be their policy to get one before they intubate. Should. If not, then they should get one immediately after. There's not going to be any point if they only just got intubated with getting another one. There hasn't been enough time to see changes. Does that make sense?
Yeah.
But in general, you want them to be as recent as possible. If you've coming from the floor, you've got a patient that was intubated 2 days ago, they haven't changed the vent settings in over 24 hours and may only be getting blood gases in the morning once a day. I'm definitely going to want something more recent than that because we're making a change. You could argue that when you're not making changes, you can do them less frequently, and as long as it's maintaining homeostasis, that's fine. We are making a change. Even if it's the same settings, we're changing from one vent to another, and that could have an effect because one may be more effective than the other in delivering a particular tidal volume at a particular pressure. We're making a change. Anytime you make a change, we need to verify and get another baseline, right?
Yeah.
Okay. So we'll keep going here. Those are going to be the ones that the reason I'm getting the patient's height ahead of time is because before I ever go to the hospital, I'm figuring this out. And when I get to the hospital and they start telling me what the vent settings are, I've already got what I know I expect to see. So if I see something else, I know what questions to ask. It's like, whoa, that's pretty high. Why do you guys have that way? And hopefully, most of the time, it should be because of the way the patient responded or what the underlying cause for them to be intubated led them to a different conclusion than what I was expecting, and I'll hopefully learn from that. All right, so the next thing I want to define is I to E ratio. If that's something without having ever learned much about vents, you probably already know what I to E ratio is, right? I to E ratio is going to be inspiration to expiration ratio. So most healthy people are at a ratio of 1 to 2. So if you're breathing 20 times a minute, that means each breath is about 3 seconds. So if you take 1 second to inhale and 2 seconds to completely exhale, that's a ratio of 1 to 2. And it's within normal range. That's a typical healthy person breathing, and that's our goal for most of our vent patients. You will see as we start talking about the different vent strategies and different vent modes, that this is going to be one of the easiest things and should be one of the first things we try to change when we're having issues with the patient, especially if they're air trapping. So get back to that COPD patient, they have a hard time exhaling fully, right? When we see the shark fin waveforms on EtCO2, we know that they're not having as much trouble getting air in as they're having trouble completely getting air out. And that's why we give them PEEP. That's why they're kind of trying to create more PEEP with their own lips, and you see the pursed lips and everything, because they're having a hard time getting all the air out. So they're having more and more CO2 build up, And since we know that our respiratory drive is based on the amount of CO2, that gives them the sensation that they're not able to breathe at all. They feel like they're suffocating. When you have a patient who's not being able to completely exhale, obviously we can lower their rate, and that gives them more time to exhale. But you want to think about that, changing tidal volume and rate as being like changing the radiator on a car. And first of all, let me say, I know I've said it already, if you change your rate, you have to change your tidal volume because you cannot change your minute volume. Minute volume has to stay the same. So right away, as soon as I've decided I'm going to change rate, this is a big deal. Because if I have to change rate, that means I also have to change tidal volume. Every time I change one thing, I need to go in a small increment, and I need to measure patient response before I make another change. So making a change to rate or tidal volume is inherently kind of a big deal, right? One way you can avoid having to slow the patient's respiratory rate down when they're having a hard time fully exhaling is you change their I to E time. Give them more time to exhale with the same respiratory rate. On this vent, and we'll play with this at the end, and when we're doing the practical stuff, you'll see that you can't actually change your E time, but you can change your I time. So if you need to extend E time, you leave your rate the same, and you decrease your I time, and that effectively increases E time. Does that make sense? So I'm breathing, got them set at 20 times a minute. I'm just using this because the math is easy. Got them set at 20 times a minute, and they're inhaling over 1 second. That means I've got the I to E time of 1 to 2. I see that they're having a hard time getting all their air out. They're air trapping a little bit. If I decrease their I time, just for the sake of argument, and this isn't going to be a good number to go to, but down to ½ second, then how much time do they still have to exhale? Be 2.5 seconds, right? So now you're 1 to 2.5, or 0.5 to 2.5, that's a ratio of 1 to 5, right? So if you go all the way down to a ½ second, they now have a whole extra ½ second to exhale, and you've increased their I time to 1 to 5, which is pretty high. Typically, for most people, like I said, you're starting at 1 to 2. For a COPD patient, you might get up to 1 to 3 or 1 to 4. You're not going to typically get above that. I wouldn't go above that without talking to a doctor first. Because, for one thing, at that point, you're really increasing pressures. Because as you decrease the amount of time that it takes to get the same amount of air in, you're producing more pressure. And that's because of the next thing we'll talk about, which is going to be flow. Flow is something that you don't directly change, but flow is literally just how fast the air is moving in. And if you've got a set tidal volume, say 450, and you decrease your I time, you're getting that 450 in a lot faster, so it's flowing faster, right? That's producing more pressure. So we still need to be careful even when we're changing the I to E ratio, but changing your I to E ratio is kind of like changing the thermostat on an overheating car. You can do that more easily and without having to change other things. It's not like going straight to your tidal volume and your rate. That's more like changing the radiator. Let's try the easy thing first. That make sense? Next thing that we're going to talk about is going to be our pressures. So define 2 more terms. Airway pressure, PAW. That's pretty obvious. That's just the amount of pressure in the airway at any given time. We'll skip over trigger for right now. We'll get back to that later. And we're going to start talking about our pressures. You guys okay if I erase this?
Yeah.
Anybody need a break? All right, keep moving. So the first pressure I want to talk about is going to be PEEP. And it's one we probably already know the most about. Anybody remember off the top of the head what PEEP stands for?
Positive expiratory pressure.
So it's peak and expiratory pressure. Yeah.
It's too early in the morning.
Yeah, so that's the amount of pressure, as the name implies, that's there when the expiration is ended. When you're at the end of your exhalation and the pressure in your airway is at its lowest, what's that pressure, right? So what if we putting PEEP on somebody, what's our typical place for starting there? 5, right? 5 is a good place to start. And for us, what's the highest we can go to? Like when we get somebody on CPAP. According to the state of North Carolina, we can go up to 20. It used to be lower, and they've slowly pushed it back. We can actually go up to 20. On these vent patients, don't go, I need a doctor to tell me to go anywhere near that high. You know, we're going to start most people at 5, right? We might go up a little higher, we might go up to 10, but that's peak and expiratory pressure. All right, so then the next one I want to talk about is going to be PIP, and that's just peak inspiratory pressure. So that is at the highest pressure as you're inhaling. When you inhale and your lungs start to fill with air before they even start to expand from that air filling, the highest pressure you get to is going to be your PIP, okay? If you've got your vent in pressure control, that's what you set. You set a PIP, and that yields a tidal volume. But most of the time, we'll probably be in volume control, I would think, with this vent come from the hospital. Have you found that to be the case?
What's the top one on there? I can't remember.
Volume, yeah.
That's what I used on one I took.
Yeah. Now, my experience has been when we're taking vent trips out of Watauga, we have the RT with us. The RT is much preferred pressure control because pressure allows the body to yield whatever the appropriate tidal volume is, and they're automatically keeping pressure where it needs to be to avoid ARDS. It's a little bit, for us, it's a little simpler. We're not to deal with those essential numbers like tidal volume. But it actually ends up being more complicated in the long run to deal with tidal volume rather than pressure, because if you don't have the pressure right, you're doing calculations again and, you know, moving it up, moving it down until it gets the pressure you want. If you just start with the pressure you know you want, if the end game is to keep pressure below a certain amount, then it's easier just to set that pressure where you know it's safe. And if it's not yielding the tidal volumes you want, then you incrementally move up the pressure, move down the pressure until it's yielding. But you still have to know what tidal volume you want, right? Mm-hmm. Which means you still have to do the calculation for tidal volume. So for us, we're just going to try to keep it more volume for now. So that's PIP. The next pressure we're going to talk about is going to be P-plat. That's plateau pressure. I'm so used to putting a T after that little P for ACRs. All right, so P-plat is a little bit harder to explain, but it's not really too bad. And you can see we've got that chart there. I see you're already looking at it there. We'll talk about those waveforms in just a second, but P-plat, or plateau pressure, is the pressure that's in your lungs after you've inspired air and the lungs have expanded, right? So look at those waveforms real quick here. Pressure's going up, pressure's going up, pressure's going up. Because I'm inhaling, I reach the peak of my pressure from inhalation, and this starts to drop off as the lungs expand, okay? If I were to hold that breath, and there's a couple ways you can do it. With some vents, there's actually a button you can push that holds the breath at the peak of inspiration. With this, we'll play with this when we got it all hooked up, but you actually just put your hand over the expiration valve and just hold the breath in for them for just a half second, just right while they're at the peak. And what that'll do is while they're holding the breath, that amount of pressure will extend long enough for you to see that number, for you to see a reading come up, okay? To avoid ARDS, the very limit of what you would want to go to on PIP is going to be 35. So you want to be less than that, right? For P-plat, it's going to be about 30. You want to be about less than 30. And this, again, is centimeters of water. If you're having numbers go up here at the PIP side, then generally that's an airway problem, okay? If your PIP is going up, that's the pressure that's primarily monitored, and it's the pressure that you can set. And if it's getting above, you got an alarm on there that if you're getting above 35, the alarm's going to go off, and it's going to tell you your pressures are too high. And we'll have a whole sequence of things that we're going to check to make sure that we correct the problem. But we want to think of that as being an airway issue, and the airway includes your vent circuit. If you've got an obstruction in the vent circuit, if you've got an obstruction in the airway because it needs to be suctioned, or because of bronchospasm and we need to give them neb treatment, then you're going to see peak inspiratory pressure increase. But you won't see a change necessarily in your P-plat. In fact, P-plat might go down because you're actually getting less air into the lungs. And you can see on that diagram, you see the upper left-hand corner is normal. That represents, let's say, like a 25 and a 20, something like that. You've got a difference of about 5 centimeters of water between your PIP and your P-plat, and that's good, and you're within range. The one next to that, just to the right, that you see it's labeled bronchospasm, secretions, foreign bodies, tube kinks. That's the airway obstruction where you're seeing PIP go up, P-plat is staying the same or even going down, so you're seeing that variation between the two widen. And what we're going to do when those alarms go off is we're going to diagnose, right? So one thing we can do real quick is put a hold on and see what the P-plat is, so we know if this is actually an airway issue. Then we're going to start here at the vent, and we'll work from the outside of the body and simple fixes all the way into the internal environment, where the very last thing we would change is going to be vent settings after we've ruled out everything else. So first of all, is my cardiac monitor sitting on the vent circuit? Is my foot on it? The wheel of the, is it kinked? Work our way down, you get to the tube itself. Is the tube obstructed because of secretions? We can suction that with a French suction catheter easily enough. Nope, nothing in the tube. What's my ETCO2 waveform look like? Am I seeing shark fins? When I listen to the lung sounds, am I hearing wheezing? So I can give them a neb treatment right in line with the vent, right? That'll help fix that. If none of those things are happening, then I need to look more at what's happening to the patient as a result of my vent settings, and maybe my pressure is just set too high, or my tidal volume is set too high and it's yielding pressures that are too high. I need to come down in tidal volume, which means I need to increase rate. But that's the last thing we get to. All right. The next thing that could happen, you see the lower left-hand corner says high flow. Remember I talked about when you increase the rate that it's coming in, you're going to see the PIP go higher. That's something you might just be stuck with. If you've got that patient you had to increase your I to E ratio, that might have jacked up the pressure a little bit more, but the acute issue is going to be air trapping. We can't allow air trapping. We've got to do something about it. That's what's going to do the least to it. PIP being a little bit higher might be what you have to accept in order to let them breathe off the CO2 adequately. And then the last one you see is on the right side. And what's interesting there, that's going to be a P-plat issue. And if you look at it, you'll notice that when your P-plat goes up, your PIP also goes up. So this all becomes steeper, and you still have a small drop-off there, but now it's all much higher, and you don't have much of a difference between them. That's because when your P-plat increases, it's an issue of lung compliance. So if you inhale, pressure increases, that's your PIP, your lungs try to expand, they can't expand very well. You're not going to see much difference between those pressures, right? It's not going to have the ability to drop because the lungs aren't expanding very well. That's a lung compliance issue. But if you have a lung compliance issue, if pressure is building up in the lungs because they can't expand, that's obviously going to drive the peak inspiratory pressure up in the airway as well too, right? This is airway, this is lung compliance. If you have inadequate movement through the airway, that's not going to have a positive increase in pressure with lung expansion because you're not getting as much air in the first place. But if you're having an increase because of low lung compliance, that is going to have an effect on the pressure in the airway itself. Does that make sense? I think those diagrams really help out quite a bit, but when we're diagnosing the reasons for a pressure alarm going off, it's really going to be important to differentiate between, is this an airway issue or is this a lung compliance issue? Once we've established that the PIP is being driven up by P-plat, because your P-plat is too high, which we have to check, then there's a whole list of things there that can cause your lung compliance to decrease, which is going to cause your P-plat to go up. So you can look at the list or not. What are some things that are going to cause P-plat to go up? What are the things that are going to reduce lung compliance? Pre-existing illness, so pneumonia, if they've already got ARDS, we've talked about that. If you've got a septic patient and they've got a large amount of ascites, which is fluid buildup in the abdominal cavity, right? That can put pressure on the chest cavity as well. So with your septic patient, you need to look for fluid buildup. Same thing with your trauma patient. A hemothorax or a pneumothorax is going to put increase intrathoracic pressure. Anything that increases intrathoracic pressure is going to restrict lung expansion, which is going to reduce lung compliance. All right, and you see there's a list there: pulmonary edema, fluid in the lungs. That certainly would do it. Atelectasis, so if you're having alveoli collapse, you're an emphysema patient, or you've got your FiO2 way too high and you're having absorptive atelectasis, that's going to cause decrease in lung expansion. And then I also got fibrosis there. But that's pretty much it. So for all those things, again, we've got our diagnostic tools that we can go through to see what's going on. We can listen to lung sounds. Are they wet? Do they need nitro? Do they maybe need to increase PEEP? Right? Because if we increase PEEP, we can help to push more of that fluid out. One thing that's going to be important when you're using PEEP as a tool to try to push fluid out, or you're changing PEEP and you're, say, in pressure control mode, when you increase your PEEP, you automatically increase PIP. Because when you set PIP here, you're only setting the amount of additional pressure that's given during inspiration. PIP is the amount of constant pressure that's always there. So by nature, your PIP and PEEP are added together to get your actual PIP. Does that make sense? Your PIP setting and your PEEP setting are added together, and that's what the actual PIP should yield. Does that make sense? Okay. So yeah, there's things we can do for that. For tension pneumo, what do we do to try to improve lung compliance if we think that it's the problem is pneumothorax? Yeah, if they have a chest tube, we can hook, and they don't already have suction to it, we can hook suction to it. If they don't already have a chest tube, we think this is new, caused by the vent, whatever, we can dart. But there's things we can do about that. Atelectasis, again, if we think that's what's causing it, then we can increase our PEEP. If we think it's pneumonia, there's not a whole lot we can do about that. ARDS, we can try to treat the underlying cause, and I'm going to call a doctor. We're not making that call on our own. This is not vent management for critical care. This is for ALS. We're getting orders when we make vent changes, period, really. But we can potentially make some changes there that are going to help the underlying cause of ARDS, so we can decrease the volume, increase the rate, and hopefully we can use tools like I to E ratio and PEEP to try to increase oxygenation without having to increase FiO2. But all else fails, you've got a patient in ARDS, you're going to have to do some things that harm them is the bottom line. Because the dysfunction is so bad, you're going to have to either increase pressure or FiO2 at some point to keep them adequately oxygenated, and then that's going to cause more problems. So that's it for the pressures. We're not going to talk really much about delta pressure, driving pressure. Everything that's in here is worth investigating, but for right now I'm just trying to hit the high points. And we've already talked about ideal body weight and how to calculate that. So now we're getting to kind of the meat of the vent itself. So what we're going to talk about now is going to be vent modes. So before we even talk about the different modes, I just want to differentiate between mode, control, and strategy. So when we talk about vent modes, those are different modes that you can get into in the vent. There's not really different modes that we use for different purposes as much as there have been historically different modes that have come in chronological succession, each one making the previous one kind of obsolete. Right? We've just come up with better and better ways to allow for patients to be able to breathe on their own over the vent and compensate for that electronically, so that we can wean patients off the vent. Again, for the patient that's fully paralyzed, fully sedated, just got tubed in the ER, those changes are there as a backup. We're not depending on them. We're trying to keep the patient from breathing on their own at all anyway. But even when that's our goal, that doesn't mean we always succeed, right? Even with those patients, we've all had those patients that were really hard to keep sedated, really hard to keep paralyzed, right? And they kept trying to breathe over the tube, breathe over the vent. When you've got that going on, you need to have these more advanced settings, advanced modes that we have now that allow for them to breathe on their own, so that they don't start air trapping as well, right? But typically, we're trying to keep them sedated and paralyzed enough that these different vent modes won't matter except as a backup. For the patient that's coming off the floor or that's kind of on the vent but in BiPAP mode or something like that, then they're going to be breathing on their own all the time. So then other modes do come into play, and making sure that you're allowing the patient to be able to breathe on their own without air trapping is important. So the first mode so the difference between that and control is that control is just simply how are you setting tidal volume? Are you setting tidal volume directly, or are you setting tidal volume by way of pressure? Are you setting a pressure and letting it yield the tidal volume that you want? All right, so that's control. And then the last thing is going to be strategy. There are two main strategies and one main exception. The two strategies are going to be the injury strategy, the obstruction of strategy. We'll talk about them in a minute. And kind of the exception to them is going to be your critical metabolic acidosic or acidemic patient who needs to have a jacked up minute volume so that they can breathe off adequate carbon dioxide to avoid dying from acidemia long before they have a chance to develop ARDS or anything else like that. Does that make sense? All right, so we'll get to the strategies last. First thing I want to talk about is modes. As you can see on the sheet there, the first mode is going to be mandatory minute ventilation. That is the most basic vent setting. So like the old school TV, ER and stuff where you see the vent that's got that little accordion thing opening and closing. Those used nothing but the mandatory minute ventilation, and that doesn't allow the patient to take a breath on their own at all. If a person who's on that mode starts trying to breathe for themselves, the vent's not going to care, it's not going to recognize, and when it's time for another breath, it's going to give another breath. So let's take a look at an ETCO2 waveform, a capnography waveform, and take a look what that would look like. So I've got a patient who's getting mechanical ventilations. They're getting these very regular intervals like this, and then they try to take a breath on their own, let's say right about here, and so you get this guy right there, and then they've got this certain amount of time to exhale, and it doesn't come all the way back down, and then the vent still gives another breath anyway, and they try to take a breath here, and so you see ETCO2 is going to start climbing up and up and up and up. That's breath stacking. You've heard that term before? That's breath stacking, and a lot of times when this starts happening before it gets bad, before it gets to the point that they're building up ETCO2, you might see this try to come down, then it goes up again. You know what this is called? Chiari clef. And this is just kind of diagnostically an indication that the patient is trying to breathe on their own over the vent, which may not be a bad thing if they're in the appropriate mode and we're trying to wean them off. But if this is somebody that we were trying to keep sedated, this is a sign that you need to titrate up your sedation. And if they're on, in particular, there's a difference between paralysis and sedation. This isn't just a sign that they're not adequately sedated. If they're on a paralytic, this is a sign they're not adequately paralyzed. Because even if they're not adequately sedated, if they're adequately paralyzed, they can't try to breathe over the vent. There's other issues. You're going to see their heart rate jack up, blood pressure jack up, things like that, the tearing. That's horrible. We want to prevent that. But you're not going to see changes on your capnography from just sedation. This is paralyzation. So that's just so the Chiari clef just shows that they're trying to breathe over the vent. When you start to see that shape that I showed you before, where mechanical breath comes in, and then they try to take their own breath on top of that, and it lasts long enough that they're not able to fully exhale before the next breath comes in, that's breath stacking. That leads to air trapping. That leads to dead space. That leads to inadequate oxygenation. You're going to see your SpO2 numbers coming down, alarms are going to start going off, and you really need to change something quick, right? So the first thing you can do if you see that they're doing that is to just pop off the circuit and let them fully exhale and then put it back on. But you're going to need to change something too, right? Either you're going to have to give them some more sedative, or you're going to have to change something, increase your eye time or decrease your eye time or something. But when you're in mandatory minute ventilation, the vent itself is not going to help you out at all. It's not going to do anything to prevent breath stacking and air trapping. So you're going to have to do it yourself. Real big pain, not good for the patient, completely obsolete, nobody uses it. but we talk about it because that's the starting point. Next thing that comes out is called assist control, right? So with assist control, what the vent does is the vent has a pressure sensor in it, obviously, because it's telling us what pressures are being yielded. So when it senses negative pressure, so you've got your PEEP set at 5, right? The vent senses that the pressure just dropped all the way down to 2. It says, this patient's trying to take a breath. I'm going to help him take that breath. So whatever you set as your tidal volume, the vent is going to deliver that full tidal volume, that full breath, to that patient when it senses pressure dropping. So that's better. That's a lot better than your mandatory minute ventilation, right? Because when a patient tries to take their own breath, it'll help them out. The problem is when a patient, as we've shown just a second ago with that, messed up capnography waveform, that patient's breath could come at any time. And if it comes at the wrong time, it's going to interfere with full exhalation, and they're still going to cause air trapping and potentially breath stacking, and then air trapping, and then dead space, and blah, blah, blah. We're down that road again. So somebody came up with an even more accurate and effective way of programming vents, and so you end up with what's called SIMV, synchronized intermittent mechanical ventilation, right? So with that, what the vent does is when it's at 5 millimeters of mercury, right, or 5 centimeters of water, sorry, and it feels that drop down to 2, it says, oh, the patient's trying to take a breath. In SIMV mode, the vent thinks about it and says, is this a good time to take a breath? Is this a smart time for that patient to take a breath? Do I have enough time if I give this breath for it to fully exhale the breath I already just gave him? If not, then it doesn't give it. And if it does give it, then it resets its own next breath to give full time for that breath to fully exhale. So you don't have to know the whole algorithm about how it works. You just have to know that this is a smarter mode. You think about technology being smart. Assist control is aware, but it's not smart. It doesn't make decisions. It's just aware that the patient is taking a breath, so it gives it to them. SIMV thinks about it. Do I want to help this breath? Do I need to adjust the timing of my next breath to make sure they have fluid? And it makes the adjustment. So SIMV is very, very effective at preventing air trapping and breath stacking with a patient who is not fully sedated and taking some of their own breaths, which, like I said, may be a problem we need to fix, or it may be the plan to begin with if we're trying to wean the patient anyway.
Is that something that we're running into as ALS providers with the transport from facility to facility?
Yes. Air trapping?
No, just the whole fact of them being in the process of weaning a patient off.
Weaning off the vent, so it could be very easily. If you're taking somebody off the floor who's been on the vent for a couple days and they've developed ARDS and that's why they're being transported, or they've developed some other condition, or they've just decided they can't treat them, they very easily could be in the process where they're being weaned off. Also, what you're more likely to find is patients who have just been intubated, but for whatever reason, with the particulars of that patient, they didn't want them to be fully paralyzed and want them to be able to breathe on their own. I could see that definitely happening with the obstructive approach in your COPD patient. They may want them to be sedated, but if they're taking breaths on their own, let them. And so you still could see that.
So you're just using the vent to support.
Right.
Okay.
I mean, I've taken vent patients who were they were intubated and on the vent, but they were just in BiPAP mode because they were intubated because they weren't able to protect their own airway, not because there was any dysfunction as far as their respiratory effort. And so there was no reason to take that respiratory effort away from them. Now, a person's got to be sedated enough that they've lost their gag reflex and will tolerate the tube, but that is possible. You can do that. So I imagine in most of those situations, most of those patients were probably paralyzed for the process of intubation, and then they didn't maintain paralyzation. They maintained sedation. And those patients get put on BiPAP mode, and every breath is patient initiated. So the short answer is yes, that is something you could see. You can see patients who are being allowed to breathe on their own, definitely. And they may only be breathing on their own when it it comes up, or they may be initiating every breath on their own. You'll also have some patients who are on vents who are just permanently vent dependent. We do those, right?
Yeah.
We do those all the time. That's not remotely critical care. And those patients, like we've got some regulars in Watauga County that we have to take to all their doctor's appointments and everything, and they're on mechanical vents 24 hours a day. Most of those patients are initiating every breath on their own, and that's just basically there to give them pressure support, and so they're in BiPAP mode, and it's just giving them extra pressure because they can't lift their chest themselves.
Yeah.
It's as simple as that. They just need extra mechanical help to lift their chest because the work of breathing eventually wears them out. And then they go into respiratory failure, not because there's anything wrong with their respiratory system, but because they can't continually lift their chest and keep breathing. That makes sense?
Yeah.
So there's a wide range of patients, and that's why there's these wide range of modes. SIMV is the great catch-all, because if you've got a patient who's completely sedated and completely paralyzed, it's giving them every breath they need. But if paralysis starts to drop off, which is its own problem potentially, it at least doesn't make the problem worse by causing breath stacking. So it's kind of there as a backup. Does that make sense?
Yeah.
Okay. So then the next two modes we'll talk about are CPAP and BiPAP. We're paramedics. What's that? And you don't do those on these.
We're not allowed to use those.
You're not allowed to do those. Okay. I still feel like for awareness sake, I like to include it, but it doesn't take much discussion because you guys know how CPAP works, right? We're ALS. We've done CPAP. We've all done it a bunch of times, and we know what it does. You know what the difference is between CPAP and BiPAP? The hospital does BiPAP and we do CPAP, right? Well, the difference really is PIP. What do we set with CPAP?
The PEEP.
PEEP and PEEP only. With BiPAP, we're setting two pressures, a PEEP and a PIP. And just like we talked about with pressure control on our vent, when you set both, one is going to be how much additional pressure is given during inhalation. The other is the baseline constant pressure. So your actual pressure yielded at peak inspiration is going to be PEEP plus PIP. But you still have to have two different settings. And again, when you're in BiPAP mode, the machine, whether you just have a simple BiPAP machine or you're using a more complicated vent in BiPAP mode, what it's doing is it's sensing that negative pressure from the patient trying to take their own breath, and that's the trigger that tells the BiPAP to move to add PIP onto PEEP. And it does it for a given amount of time, and you're back down to your baseline, which is PEEP. Does that make sense?
Yeah.
So that's your CPAP and your PEEP. So that brings us right to the strategies or approaches. I've already mentioned what they were. So for obstruction, we've already said your COPD patient, your emphysema patient, your asthma patient, anaphylaxis, whatever, they're intubated because they were in respiratory failure because of obstruction and bronchospasm. That patient you're going to look at with what we call the obstruction approach, and what we're most worried about there, we're worried about ARDS and ALI, but we're even more worried about breath stacking, air trapping, not being able to fully expire, really more air trapping than breath stacking. And so the approach we're going to take there is going to be low rate and higher volume to allow more time to exhale. We can always adjust I to E time to help them out with that, so as to minimize the negative effects on preventing ARDS and ALI. The only people that we're going to use the obstructive approach or strategy for is going to be those COPD, asthma, emphysema. It's got to be an obstructive airway issue for us to take that approach. For pretty much everybody else, whether they're intubated because they were in septic shock, they were intubated because of a head trauma, they were intubated because of benzodiazepine overdose, whatever happened that caused them to not be able to protect their airway and get intubated, it had nothing to do with airway obstruction. That's most people who are getting intubated, especially your trauma patients. So for all those patients, our number one concern is preventing ALI and ARDS. So we're going to take an approach that requires a lower tidal volume and pressure and a higher rate. And that's the injury approach. We've already discussed how to do that. You guys feel comfortable understanding the difference between those two approaches? those are the only two approaches, by the textbook. But then the textbook also names another one, but it doesn't name it as an approach or strategy. So I call it an exception. But that's going to be basically your DKA patients, your extreme metabolic acidosis patients. And the change in strategy there is, we're worried about breath stacking and air trapping. Yeah, we're worried about ARDS and ALI. But this patient is so acidemic that if we do anything to try to prevent those things from happening, they're going to die from their acidemia long before they have a chance to develop those. So we have no choice but hyperventilate this person so that they can breathe off enough carbon dioxide to compensate for the metabolic acidosis so they don't die right now. So your DKA patients, the way we're going to look at that approach, in layman's terms, what we're going to do is hyperventilate them. And we're going to try to keep them as close to what their natural compensatory respirations were. So if they came in breathing 36 times a minute and near full lung capacity, then that's what we're going to calculate. And we're going to try to keep them as close to their natural compensation as we can. If you've got a patient came into the ER breathing 36 times a minute, and they were big deep breaths, they were presenting with Kussmaul respirations, and we tried to normalize those respirations when we put them on the vent, and now they're breathing 20 times a minute at 500 milliliters. That still may seem like a lot, but it's nowhere near enough for this patient. There's a reason that was not an ailment. Those respirations. That was the compensatory mechanism that was keeping them alive. When you've got somebody who's in DKA and they've got a blood sugar of 960, are they trying to fix that blood sugar problem as fast as they can and get it back into normal, or are they trying to come down gradually and slowly? Right, for the sake of the underlying condition, it's got to be brought down slowly, which means for that entire duration, they need to keep breathing this unhealthy rate and volume just to maintain. And then we can start weaning them back and hope we haven't already caused ARDS and whatnot. But first, we've got to keep them alive while we treat this. So the technical way to approach that, according to at least the Flight Bridge book on this, was to double the number for your minute volume. So for your DKA patient, for your extreme metabolic acidosis patient with ventilatory compensation, you're going to see that VTE is going to equal, instead of 120, it's going to be 240 milliliters per kilogram of ideal body weight. So that's going to give us our minute volume. Our minute volume doesn't change. And whatever the rate was that they came in with, we're going to divide that large volume by that rate, and that's our goal. It might be so fast, so voluminous that they're not able to breathe off, and then we've already talked about we can try to decrease I time to give them more time to exhale. I'd say with this approach, you're going to have to max out your I to E time, be like 1 to 3, 1 to 4, because they're going to be breathing so much, so fast. The only way they're going to get it all out is to increase your flow, which is decrease I time, give them more time to exhale. But it's not going to feel good. You're going to be looking at this patient and knowing, this doesn't look right. I'm hyperventilating this patient badly. But it's what they were doing to themselves because they needed to, and we need to continue that. Does that make sense?
Yeah.
You guys have any questions about anything I've talked about? I mean, I know that's a lot, especially it's brand new. A lot of it's brand new information. I know retention isn't going to be 100% from one exposure. Got to keep practicing. I'm happy to do this again and go into more detail, get into the oxyhemoglobin dissociation curve and some of the other things, a little bit more detail on flow and stuff like that. But for right now, I think that's a pretty good introduction. You guys want to come over here with the event and we can do a practical session. I'll give you guys, what I'll do is I'll give you 3 different patients, one for each of the 3 different approaches, the 2 approaches, 1 exception, however you want to look at it. And we'll come up with what you guys think the event setting should be based on the information we just discussed. And I'll let you guys physically set it up and everything. This is your event. I know I've played around with these lessons. I haven't transported somebody with this, so Porter, you're going to be better than I am for sure at setting it up, getting it hooked up. But we're going to work together. We're going to get it hooked up, and then I'll just give you a patient's size. I'll give you their blood gases. I'll probably make a reference to, I don't want to give you too much information just for time's sake, but realistically you'd be getting what medications they've gotten, how they responded. You know, this is all on top of their chief complaint. But I'm just going to give you basically everybody's everybody's vital signs are going to be more or less within normal limits for the purpose of this scenario. But I'll give you blood gases, and those will pretty much all be within normal limits because we just want. I'm not going to give you anything tricky. I'm not going to give you something where the vent settings at the hospital are way off and you need to fix them. That's more of a critical care exercise. We don't come in and fix what the hospital did wrong. If we think the hospital did something wrong, we have a discussion with them, and ultimately we go with what they want us to go with. We can try to change their mind, but we're not going in to correct what they did wrong. So that's not going to be exercise. I'm going to have you for all these exercises, just for the sake of practice. They're not on the vent at all. We're going to have you come up with the settings and put them on the vent yourself at the settings you want, and they're all going to be very straightforward for the approach. So let's say the first patient is going to be a patient who, end-stage lung cancer patient, history of COPD, long-time smoker, and they came in respiratory failure. They were given numerous NED treatments, put on CPAP and BiPAP. They still weren't responding, so ultimately they discussed options with the family. Family wanted everything done that could be, and so they intubated, and now the patient's going down to Forsyth. What approach would this be?
This should be more of a lung damage, already damaged type
Right,
situation.
so this is the respiratory dysfunction is the underlying cause, and would you say that that's obstructive with history of COPD and lung cancer?
These are pretty well self-explanatory. The big one goes on the front. That's what I was thinking. Some part of it's gone. This is not a functioning circuit.
It is not?
No.
That's the one that...
Well, I mean, so the big one would go there.
Yeah.
The one would go there.
Do you think there's one that's functioning in there?
Probably. Not I know what that.
Okay. Well, if you don't mind looking out, we'll discuss. So do you think this is obstructive or injury approach? Are you more worried about ARDS or with a lung cancer COPD patient, end stage respiratory failure?
I don't think, as far as, we're going to worry about ARDS, what, I mean, like.
Yeah, we're always worried about ARDS. So
Yeah.
But for this patient, I'd say we're looking at the obstructive approach.
Yes.
It literally has COPD right
Yeah.
there in the history, and that's part of what's going on. And the lung cancer, that's obstructive as well, isn't it?
Yeah.
Right? So this is an obstruction approach. So are we going to go with low rate, high volume, or higher rate, lower volume?
It'd be, would we go with higher rate, lower volume?
For the obstruction approach, we're worried about them not fully exhaling,
Yeah.
so we need to give them more time to exhale. So this would be a slower rate.
Yeah, slower rate. Yeah.
Okay.
Sorry, I had it backwards there.
No, that's why we do this. Like I said, this takes multiple times.
Yeah.
Like anything else we do. You know, this is normally
First time I've touched one.
exactly. And normally when we do training, we're doing things that we do all the time and trying to hone it and fix the little things.
Yeah.
This is first time through. We're just trying to get some experience, and it's going to take multiple exposures. So yeah, we'll wait until before we turn it on. We'll let him get back. Hopefully, we've got a working circuit for this. We can try it. Try to see what was wrong. This is the problem. That's been cut. You see that?
Yep.
You try to tape it up. I would do that on a patient, but we might end up having to do that for this.
Yeah, those didn't fit either.
Yeah.
I wonder if those are backwards.
Or somebody did this, cut it off to be able to do that. But anyway, while we're waiting on the circuit to get back, why don't we talk about what the settings would be and do the math on that. So let's say that this is a male and he's 6 feet tall.
Okay.
So the chart,
Right here.
there we go. So he's 6 feet tall, and according to the chart, for a male that's 6 feet tall, our ideal body weight is going to be 80.7 kilograms. So what's the first number that we want to calculate?
First time we want to calculate our minute volume.
Minute volume. And how do we calculate minute volume for this person in the obstructive approach?
It's I forget the actual formula.
It's 120
120.
times 120 milliliters times their ideal body weight, which we said was 80.7 kilograms. So I'll put that in my calculator, but that's not in your head kind of math.
No math's in my head kind of math for me.
80.7 times 120. I got 9,684. So you're going to want to write that in big numbers and circle it or underline it, because that's the big one that does not change.
9,000.
Thank you, Porter.
There we go.
Getting that set up.
9,001.
9,684. If you wanted to say 9,700, I'd be okay with it. But honestly, I like rounding off as late in the process as possible, because the earlier in the process you round off a number, the more that difference gets multiplied over calculation after calculation.
Yeah.
So 9,684. All right, so we said we're going with the obstruction approach.
That's VTE, right?
That's VTE. Yeah. Good job. So the next thing we need to figure out is going to be rate and tidal volume. And before we can do that, we need to know where in our range we want to end up. We already said, because we're thinking this is obstructive approach, we're going to want to be on the lower end of rate to let them breathe out.
Yeah.
So you can, to calculate tidal volume, would you be more towards 4 milliliters or more towards 10 milliliters per kilogram for a larger tidal volume?
Larger tidal volume would be lower.
Would be larger. The rate's going to be lower.
Oh, yeah, okay.
This
yeah.
is literally
Rate's
number
lower.
4 calculating tidal volume. So if I want a larger tidal volume, I've got to plug in a larger number.
Yeah.
Right? So what did I say? You don't want to start right at 10.
Yeah.
It's too high. Where would we start
6.
then? 6 is going to be good for the injury approach. But we've decided for this patient, we're going with the obstructive approach because of the history of COPD. And so we're going to start with 8.
Okay.
So that's going to be 8 times the ideal body weight. Again, calculator.
That was 80.7.
Yep, 80.7 times 8 is 645.6. So we're going to say about 650 is our tidal volume for that 6-foot patient. That's pretty high. 6-foot patient, though, I mean, that's not terrible, but that's pretty high. But we knew it was going to be a little bit on the high side because we're worried about obstruction.
Yeah.
They need to be able to breathe out. So now if I say 9,684 divided by 650, I'm going to get 14.898461.5. So 15. 15 is going to be my rate. So if I want to set this at 650 with a rate of 15, then all I have to do is really punch this in. And we'll show you exactly how to do that. And I'll let you guys do that. Porter's actually played with this. So the first thing you're going to have to do is turn it on. And then you've also got a couple other settings. So
We're an adult, right?
we're an adult. Right? So you also need to set, in addition to tidal volume and rate, we need to set PEEP. So we typically start people at 5. So
Yeah.
if I just start this guy at 5, right? And then the last thing we need to set is FiO2. All right, with FiO2, we already said normal range is going to, it's going to depend on what their PaO2 is.
Yeah.
We
And that was
we need to have a blood gas. So let's say for this patient, the blood gases showed they've been on the vent now for about 2 hours while they were waiting to get bed assignment down at Forsyth. And the most recent blood gas they got right after you got off the phone with them, you asked for one and they got it while you were en route. And it showed that pH was going to be at 7.37. PaCO2 was at 60. Let's make it higher than that. PaCO2 is going to be 80. And your PaO2 is going to be 107. Bicarb, we'll just make it normal, make it 24. Because like I said, we're not worried about bicarb for this discussion. All right, so let's see what we've got set up here.
This is pretty much the settings off of the man I took. Well, I guess it is because that's the last one we used it.
Was it? So when we set this, well, first of all, let's talk about the numbers. and what we're going to want to set. We've already decided what we want to set tidal volume to. We've already decided what we want to set rate to. We've already decided we're going to start PEEP at 5 because we're going to start pretty much everybody at 5. FiO2, is that PaO2 of 107, is that in normal range or is it too high?
It's too high.
And with a COPD patient, what do we think of PaO2 that's too high?
The drive.
It's bad, real bad. We're
Yeah.
pushing them towards, in addition to making the chance that we're going to cause ARDS worse, which is already a possibility because we're overinflating them a little bit for what we would ideally want because of the COPD and obstruction issues. So we're increasing our risk of ARDS, we're increasing our risk of hypoxic drive. We need to get back into normal range there. So FiO2, let's say they're on 100% right now. It's our goal to back them down, right? So over the course of transport, what we're going to do is try to incrementally bring down that FiO2, monitoring SpO2, and at any point you start to see SpO2 drop at all, that's where you stop. And if you need to, you might need to bump it back up just a little bit if SpO2 is still dropping. Does that make sense?
Yeah.
But our goal is going to be about 40 to 50%. You got to think end-stage lung cancer COPD patient, without even telling you, when you ask them, are they on oxygen at home, what level, are you expecting them to say, oh no, they're on room air at home? No, this patient's on oxygen. That 40% to 50% is probably baseline. 40% is not much more than being on 2 liters, and 50% is not much more than being on 4 liters. You know, so this person might already be getting to 40 or 50%. That is baseline for them. If we're at 100% now, are we just going to, like I said, we're going slow incrementally, so we're not just going to set it at 40% and see how it does, right?
Yeah.
So I've asked some people, I'm not claiming to be an expert. If you're not sure, ask the doctor about weaning down, and if he wants to tell you every 10 minutes, try to bring it down 5, he may prescribe something, or he might just say, just move it down a little bit at a time. If he gives you something ambiguous like that, I'd say, for me, I feel safe moving down initially about 5 or 10% every 5 to 10 minutes. So say about 10% every 10 minutes. I've asked some folks
That is
there.
my vent sentence.
Is it? Look at that. So yeah, I've asked some folks. I've asked Nate. I've asked some RTs, and some of them say if you're already over the limit, if you've got a brand new blood gases that tell you your PaO2 is already above 100, it's too high, and you're at 100%, you can probably drop it right down to 75%, see how it does. But then beyond that, you're working small increments. You're waiting 10 minutes in between, making sure this PaO2 doesn't drop.
Yeah.
Okay. All right. So they're at 100%, and we want to drop it. Let's go down to 80%. So our initial FiO2 is going to be 80, and it's our plan to wean back over the course of transport. So let's write all those up. We've got 650, 15, 80%, and 5. All right. So Brandon, come on over here, and Porter's going to show us exactly how to enter those settings.
We can shoot that. What, as far as our want our tidal volume to be 650.
So you see here where it says VT, there's a button right there, and then up here is where you scroll up and down. So you just push the value that you want to set, and then you up and down until you get it where you want. Push it again, and it's set.
Okay.
All right. So then, what's your rate?
Our rate 15.
So BPM is breaths per minute. It's upper right-hand corner of this setting box. Yep.
15.
15.
And our minute volume is 9,684.
We don't set minute volume.
Okay.
Minute volume is just
That's
yielded
right, yeah.
by your tidal volume
Yep.
and your rate. All right. So the next thing we're going to set is going to be
Our
what?
PEEP.
All right.
Want our PEEP at 5.
And you can see PEEP is just right there below breaths per minute. It's already at 5 because that's, and it most time will be.
And our FiO2 is going to be 80%.
And we can't actually set that because we don't have an oxygen tank here. But you see right here,
Yeah,
percent
you're
O2.
Yeah.
You see what it reads there? If you just simulate, you set that the same way. You press this, up,
Okay.
up, and then press it again and you're set whatever you want. When you want to come down, just press it, come down, couple, set it again. All right,
Okay.
so we don't have an oxygen tank with us, but we're saying we're at 80% now. All right, so you got it all set up. Now, load and go right now, or since we just made event setting change, we're going to want to,
Chill just a minute.
right, so we're going to tell the ER, all right, we're going to just wait here for 15 minutes, get the rest of our monitor and stuff hooked up, get our vitals, see how the SpO2 is doing, listen to lung sounds, all the assessment that we would normally do, and then some, because we're also going to need to assess the whole circuit. Every time we're assessing a patient, we're starting at the end of the circuit, and we're going through and doing our full assessment. All right, you guys have any questions about that patient? What are we expecting to see with these kinds of settings as far as pressures and stuff like that? Remember, we want to keep below 35 and 30, right?
Yeah.
Yeah. So if you see where you're going to see what is yielded here? This is our vent settings. This right here, this block, that's showing us what's actually yielded, right? So watch this number come up. This number is not coming up very high because the mannequin we're using is blown out and doesn't put an adequate resistance on. But what you would see is this would go up to whatever, and I'm guessing it should probably be in the low to mid 20s for this patient. For a patient injury approach, since we've got a higher tidal volume and we're obstructive approach, probably going to be more in the high 20s, hopefully.
Yeah.
Is where it's coming up to, and then that's showing you your PIP.
So we're not going to change none of the PIP or any of the pressures, right?
You can't change this.
Okay.
Well, you can change your eye time here, but the rest of this is determined by what you put in.
Yeah.
These are your settings.
So we can't go.
This is what is yielded. This is what the computer inside the vent is actually reading.
Okay, so this is not the modes. Oh, this is the
This
modes,
is
not
the mode up
Okay.
here. If you want to change your mode, you just hit that and then up and down.
Okay,
Yeah.
so I'm just looking for sure if we could run it by pressure.
Yeah, and right now we're in AC mode. That's assist control. Remember, assist control for this patient, if they breathe on their own, it's going to give them the breath every time. So if we wanted to change that, if we wanted to protect this patient from breath stacking a little bit more, what's the mode we can change to?
It's
Right here.
it's AMV.
Right, so mode select. There you go. And it doesn't even change any of these because all these settings are still relevant for SIV. All that did was tell the machine, hey, in case they start breathing on their own, I want you to back me up a little bit.
That's pretty much the catch-all.
Yeah.
Okay. So that's what we're going to transport in.
That's better. If you've got the option, I'd want to be in SIMV.
Is that something we need to ask the doctor about, or?
Well, you can ask.
Yeah.
You probably won't get a good answer from the doctor because it's like, go to RT and then RT will say, well, this is what our bid settings.
Mm-hmm. The more the more you learn, the more you educate yourself, the better your conversation you're going to be able to have. The more likely they are to be able to say, if that's what you prefer. They're not going to say, oh yeah, if that's what you prefer, go ahead and do it. If it doesn't sound like you know what you're talking about. And right now they're still getting used to the idea of us knowing any of this, and we're still getting used to the idea of us knowing any of this, right? So initially you're not going to get much response, but over time, you know, like you think about it, with the things that they know, we ask for things, we're a little bit more likely to get them, right? So we're on a learning curve here, and over time, I would expect that if we have intelligent things to say about why we prefer something, we've got a chance of getting it.
Yeah.
But in the meantime, at the very least, we should still start having that conversation. And for right now, it's more likely just to be a learning opportunity for us than anything else. We can learn why they want it to be this way. But they're not. But you know, even if that's our goal, if we go in there and we can't present ourselves as knowing more than they think we know, they're not even going to give us a detailed enough answer for us to know anything.
You want to get a report.
You might as well get your parents saying because I said so. You know what I mean?
Yeah.
And you're not going to learn anything from that. If we have a legitimate concern and we can articulate that properly, at the very least we should, if they're doing their job, if they're doing what they should, we should at least get a response that we can learn from, that we can come to an understanding of why they want this instead of that.
Yeah.
Right? So we've got the mode, we've got all this set, you understand this is showing us what we're reading. Let's say for the sake of argument that this is coming up to 28 every time. Our PIP is 28. We've got it set by volume control, so we're setting tidal volume, we're not setting pressure. But our pressure is within where we want it to be. It's kind of on the high side, but it's within where we want it to be. It's less than 35 easily.
Yeah.
What's the other pressure that I want to know about?
The PIP and the PEEP and
P-plat.
the PEEP.
And the P-plat measures what?
Less than 30.
Less than 30, and what's it measuring? If the PIP is measuring the pressure produced by the airway, it's measuring the pressure produced by lung compliance or lack of lung compliance. So the way we're going to measure that is I'm going to take this little valve here off. He said some vents have different ways of doing a hold. With this vent, you have to do it manually, mechanically. So what I'm going to do, you can hear easily when it's giving its breath. And right when it's at the peak of the breath, I'm just going to cover this up so this can't exhale. Now see that, how it stayed high for a second?
Yeah.
The reason it didn't stay high longer was because, again, the mannequin's blown out. But you just hold it there for a second, just long enough to see what it says at the peak, and then let go so that the patient can actually exhale, and you've just recorded your P-plat. The number that it hung out at for a minute is your P-plat. Now with some fancier transport vents, they actually have a waveform, so that those examples of waveforms you see, you can actually compare that to what you see. Here, with this one you only have numbers, but that's all you need. If you've got a difference of more than 5, if I held this, let's say we were at 27, I held this, and my P-plat came back at 12, something super low. And what tells me is that, relatively speaking, my PIP is actually pretty high. So that I'm looking back at my ETCO2, am I obstructed, do I need to do neck treatment, stuff like that. If it comes back, my PIP is 27 or 28, and I do my hold, and it only drops down to 26, okay, that's barely any difference at all. I've got no lung compliance. My lungs aren't expanding like they should. So we need to go down our list of things that could be causing that. And they could be chronic underlying conditions. With this lung cancer patient, expect low lung compliance, expect high P-plats. And that's probably baseline. There's probably nothing you can do to fix. But you still want to check it, see what it is, so that you can trend it. Is it getting worse? Because you still might need to do something about it. Does that make sense?
Yeah.
So for me, I'm going to want to do that at least 3 times in a round. Depending on what the issue is, and if it's an issue where I'm really concerned about lung compliance, let's say it's a trauma patient, they had chest trauma, and I'm worried about them developing a pneumothorax, or maybe I know that they already have a pneumothorax, they've got a chest tube, or it was a tiny pneumothorax, and they said it didn't need a chest tube, they'll take care of it down there in surgery, then I'm going to be checking that a lot more frequently because I'm that much more concerned about lung compliance. The more concerned I am about compliance, the more frequently I'm going to do P-plats, but it's not something you want to do constantly, because every time you do it, you're making it hard, at least in that one breath, for the patient before you exhale. How often do you want somebody stuck and then putting it over your mouth and preventing you from exhaling? Not very often.
Yeah.
But it's a diagnostic tool,
So
we do as much as we need.
The lower the difference in those two numbers, the less compliance.
Correct.
Okay.
That's right. Yep. All right, so you guys feel pretty good? Any questions about this patient? Okay, everything's already hooked up. I'm just going to change the patient. This time it's going to be a head trauma patient. Isolated head trauma, let's say it was an assault. They got hit in the head with a baseball bat. And this patient came in combative and agitated, disoriented, and vomiting. So very quickly, the RSI to protect the airway. Do you see any reason why this would be the obstruction approach? Then by default, it's going to be injury approach. Let's say this time it's going to be a female and she's 5'4". So according to the chart, she should be 54.4 kilograms.
54.
54.4 kilograms.
Okay.
All right, so if we're looking at the injury approach, we're going to be going with higher rate, lower volume.
Yeah.
Okay. Since we're coming up with what our ideal would be, I'll let you decide what rate you want to go. If you want to go for 20, you go for 20. If you want to go for 16, go for 16. Do not go below 16. But I'll let you pick and I'll let you decide whether you want to figure out tidal volume and divide that into your minute volume, or just pick your rate, divide it. You can do it either way you want, but you need to do both calculations either way so you check your number.
Yeah.
But
So
the most important thing is to do minute volume first.
Yeah. And minute volume is 120 times the kilograms. So
Yep. Which is going to yield 6,528.
You said 6,000.
Mm-hmm.
What?
528.
All right. So now we need to do the respirations, correct?
Right. So where do you want to start? What kind of rate?
We'll go with 17.
Okay. That works. Everybody always goes for even numbers. I like it. Look for the odd number.
Yes.
So just going to divide that by 17, right?
Yep.
$384. So I think on this event we'll see, but I think you're going to end up having to pick between 375 and 400.
All right. So that is our tidal volume.
Mm-hmm.
384, correct?
And we've got our rate. Yep.
Yep.
And our FiO2. We're going to need to know what the blood gases are before we figure out what we want our FiO2 to be, right?
Yep. So what is our blood gases?
So blood gases showed pH of 7.42. PaCO2 is going to be 37. Your PaO2 is going to be 92. And your your bicarb is going to be 24 again. It's going to be 24.
Speaking of PEEP, we'll start our PEEP at 5.
Yep. Yep. And FiO2, again, we're going to find out what they're on right now. But ideally, again, we don't want to over-oxygenate. They used to say
92 right now.
hyperventilate because we wanted to over-oxygenate head traumas. Now we're titrating to a particular ETCO2, right? Yeah. All right, so we could still potentially get away with 40 or 50%. If this is multi-trauma, they're probably going to be more likely to be higher oxygen content just because of hemorrhage and stuff like that. But and shock. So, if this was with isolated head trauma, they may not. If they're not seeing signs of shock and stuff like that, they may already be at a reasonable FiO2. They may not be at 100%. A lot of times they'll start high and wean down. So let's say that they've got them at 50% right now.
50%.
Yeah. So if they've got them at 50%, and we've gotten PaO2s in the 90s, do we need to make any changes to that?
No, I mean not necessarily.
Yeah, I'm
we're
happy
within
with
normal limits.
Yeah.
But I wouldn't make no changes unless anything changed.
Yeah. So we'll run with it. I think we're getting a low pressure alarm here because of lack of compliance here. But we're going to, so we don't normally do this, but we're going to just ignore this alarm because we know it's being caused by a bad dummy. Yeah. All right, so go ahead and use your fingers this time, and let's get those settings. I'll read them off to you as you want.
So, breaths per minute 17, PEEP at 5. Our tidal volume, what is it? 384.
Yep.
Can't do that.
Just to see how close you get. You see how you're going to have to choose between 375 and 400, right?
Well, yeah, and the closer would be 400.
It's going to be a little closer to 400.
Yeah.
Just round off, just like you ever would. And then and know that you round it up, so you're going to be a little bit more likely to check your PIP and make sure it's not too high.
Yeah.
And if it is, come down to 375 without changing rate because you're still at your same goal minute volume there.
Would you err on the side of the lower end of 375 or?
Not necessarily. I'd round off. If you were 378, I'd be going down to 375. 384, actually, you can go down to 475. By 387, you're rounding up to, or 387 and a half, you're rounding up to 400. But honestly, it's in between there. You pick either one you want, go with it, and just know that you're watching for adjustments.
Yeah.
Now, we said that our goal on ETCO2 is going to be 30 to 35 because of head trauma, right? We're trying to titrate. So what happens if we see that or our ETCO2 is higher than that. So our PaCO2 is 37. If we get them hooked up and find out that what we're reading on our monitor is actually like 40, and we need to bring the CO2 down, what changes do we make here to try to bring CO2 down?
Respiration.
Right. Now, when we change rate, we change tidal volume, right?
Yeah.
So in this case, when
We
you
would
increase
change-
rate, would you also decrease the volume?
No,
We
you
would
increase
change
the
our
volume.
eye time.
Right. You would at least, or at least you would keep it the same.
Mhm.
Because that's the thing, when I do this, everybody says the same thing. If we need to bring ETCO2 down, we increase rate because that's what we're trained to do because we're just bagging and we're not measuring tidal volume. So all we have to do is change rate. But when we change rate, we're changing rate and keeping volume the same. We're not thinking about it that way, but do you squeeze harder or squeeze less because you just increased the rate? No, you're still squeezing the exact same amount.
Yeah.
Because the only thing that's going to affect the amount of carbon dioxide you're breathing off is minute volume. If you're making the changes to rate like we normally do, or we need to increase rate, ETCO2 is too high, but you decrease volume with it, as long as you're still breathing out, in and out the same amount of air, you're still breathing off the same amount of CO2. So you're not going to affect any changes in ETCO2. The only way to change ETCO2 is to do what we normally don't do, which is to change minute volume. The way we change minute volume is increase rate without decreasing volume. Okay, and we need to do that very, very, very carefully for all the reasons we've talked about before. But if your goal is to breathe off more CO2, if you want to call, I'd probably call the doctor and say, I've got ETCO2 of 42 now. I'd like to increase the minute volume. I'm going to go up my rate to 18, and if that doesn't work, I'll go up to 19, and I'm going to leave the tidal volume where it is and get them to approve that, get the orders for it. But you're not going to breathe off more CO2 unless you increase the minute volume.
So curious. I want to see.
Yeah, play around with it.
So much pressure on.
So you've got the rate up to 200 now, and you've still got the volume at 400. So every time you're making a change like that, what else do we need to calculate and document? What the new minute volume is,
Yeah.
why we made the change, how the patient responded. So what's their new ETCO2? And when it came back down, what do? Try to get back to that regular minute volume if we can. Try to level off because we don't want the ETCO2 to continue to drop.
Yeah.
We want to get it down into 30 to 35 liters there. What if ETCO2 was the same as PaCO2? What if it's coming back at 37? Are we going to bother to change minute volume to try to drop ETCO2 by 2 millimeters or 2 centimeters of water?
No.
No. No. We're pretty close
If your
there.
patient's that bad, you got more stuff going on
Right.
than worrying about.
That's pretty close. Now, like I said, you're up,
Well, if
you're up
you're
over
changed,
40,
if it's a
it's
big
high.
change.
Yeah, but 36, 37, if it goes, it depends if it's trending or if it's staying level. Okay. Can you think of anything else we might need to change on this patient? Looks like you got the settings in there the way you wanted. So
Just
up to 20.
monitor.
So let's go back to our original setting of 17. Let's say that their ETCO2 is good. Their ETCO2 is 34 at those settings. So we're going to keep it where it is. Feel good about this one?
Yeah.
All right, so let's talk about the exception. DKA patient, blood sugar was 1100, came in respiratory rate of 36. It's a 5'8" male, and let's figure it out from there.
You want to do the figure in quarter?
No, you go right ahead. My math ain't good this early in the morning.
I'm relying on Pete's math.
Well, you tell me what we're doing, and I'll punch it in.
All right. So what'd you say? It's what? 5 foot? What?
5'8" male, which gives you an ideal body weight of 69.8.
So as far as
I'll go ahead and give you the blood gases too now.
Okay.
So we'll give you pH comes in at, let's make it bad, real bad, 7.12. PaCO2 of PaCO2 is going to be 30, or maybe make it 25. SPO or PaO2 is going to be 85. And your bicarb actually is going to be different on this one. Your bicarb is going to be 12.
Okay.
Right. So we're not going to worry about the bicarb. I just hopefully it will be different. So they're extremely acidemic, right?
Yep.
Do you know the difference between acidemia and acidosis? So when you see somebody's acidotic, osis is a trend or a process. Emia is a state.
Okay.
So,
So EMEA is more acute.
well, it means it's a
They're
state.
staying there.
They're there.
Oh, okay, they're staying.
So
Okay.
if you're acidotic, that means that there's a process in your body that's pushing you towards acidosis, but there may also be compensatory mechanisms that are pushing you towards alkalosis and balancing it out. And it's only when those compensatory mechanisms start to fail, which inevitably do with all compensations, that your actual pH will start to come down. When your actual pH comes down, you're acidemic.
Okay.
Right? So this patient's extremely acidemic, right? And you already said blood sugar is like 1100 or something like that. Something crazy. So we know what this patient needs to be doing, and we said that they came into the ER breathing 36 times a minute.
Okay.
All right, so now let's figure out what we think their tidal volume and minute volume should be, and we're not going to figure out what it should normally be. We're going to go with that 240, right?
Yeah.
Instead of using 120, 240 times their ideal body weight. So let me plug that in for you. Unless you can do it in your head.
Oh yeah.
69.8 times 240.
Oh, that's elementary math there, Pete. Come on now.
Of course it is. It's 16,752, which is a whole lot higher than the minute volumes we've been getting, right?
16,000 what?
16,752, and that's for a guy who's 5'8". We just did a guy who was 6 foot. Right. Which is appropriate. We are deliberately hyperventilating the crap out of this person because that's what they were doing to themselves. Because right now, that's the only thing that's keeping their pH down, right?
Yeah.
Their body can't produce bicarb fast enough to keep up with the metabolic dysfunction, so the body's breathing off CO2 to try to maintain adequate pH level, and it is failing. So what happens if we put this patient on at 20 breaths per minute?
Then
The acidosis is going to get worse.
Yeah.
And what happens if acidosis gets worse than 7.12?
They die.
They die. They just die. All right, so let's figure out your tidal volume next. So the way I'm going to do that, the first thing I'm going to do is come up with my goal. So, and we're gonna have to play with this and then do more math. So they came in breathing how many times a minute?
36.
36.
And we want to be as close to that as we can.
Yeah.
So let's divide that by 36. And you get 465. Now that's a reasonable tidal volume. Okay? But at that rate,
That's a lot.
at that rate, that's a lot. And at that rate, they're going to have a hard time breathing off a little bit. So now if I were to come down to 30, if I were to divide that, keep that number up there for now.
Okay.
If we're going to divide by 30, that would give me 558. So 550 or 575 is still a reasonable tidal volume, and 30 still gives them a little bit more chance to fully exhale, right? So am I going to knock out their compensatory mechanism if I change it to 558 and 30?
No, because you're increasing the tidal volume.
Right. The minute volume stays the same. That's
Yeah.
what's important, right? When it comes to breathing off carbon dioxide, the minute volume is what's important. So, yeah, so why don't we try that? Because honestly, if I remember right on this vent, I don't think the way we've got it set up, it even allows you to go above 30. I think we tried one.
I don't know. I can't remember.
It might. I think it was something
Alright.
that you can
So-
change. But either way, I feel better about 30 when we got them on a mechanical vent because I don't want them to start trapping air either.
Well, could you change your I to E and
You can absolutely.
with that.
I would, and that's the other things I'm gonna
Okay.
max out my I to E also
Yeah.
because of the rate, even at 30. So go ahead and set this up for 30.
'20s eyes will go?
That's been changed. We definitely got higher than that before. So you'd have to go into your parameters to be able to change that. And for this patient, it would be worth it. Call somebody, figure out how.
Try it again, see if it,
Yeah, it won't let us go any higher.
can you try a different mode?
We could try custom, maybe. No, it still won't let us go above 20. That is something that can be set, but you're going to have to call somebody who knows more about this particular machine to go into parameters, because I know before we were able to get up to 30 without a problem, and we tried to go higher and it wouldn't let us. So you can set what the maximum is going to be. But so if we had it at 30, go ahead and set the title volume, and then we can figure out what it would be at 20. But there's no way we'd be able to get that title volume in.
I did, but it sounded like it was really struggling to put air into it, so I didn't want to.
Oh, it's okay. Go ahead.
Okay.
Yeah.
It's 5, what? How 75?
Mm-hmm. I'm going to play this. There you go. So now you see the pressure going up?
Yeah.
That's because I'm just backing it up, pretending to be resistance from the lungs. And then a hold would be like that. Yeah. All right, so you see how that would work? We've got it set at 575. How about with 85 being our or PaO2, what are we going to set FiO2?
You said
For this patient?
85, so we're going to set the FiO2 to probably
If they've already got it
40
set,
or 50,
I'm gonna leave it
yeah.
where it is, and if not, then let's
because
try.
I mean that's fine where it's at.
Are they on any oxygen right now? Let's maintain how much oxygen that is, because I like that.
Yeah.
Because and you can even figure out what the how much oxygen they're on. If they're on a non-rebreather, then they're at 15 liters. They're at 100%.
Yeah.
If they're on nasal cannula at 6, then prior to being intubated, that's going to be more like 15%.
Yeah.
And you can figure that out, but yeah. So let's say that they're on 60% FiO2 is what they've been saying they already had. So we're going to keep that, right?
Yeah.
PEEP. We're going to change PEEP.
Leave it at 5.
I'd probably leave it still starting at 5, but that's something if they're having that you might end up changing if they're having a hard time oxygenating because you're stuck in with such a fast rate and you go through a real short I to E time. So let's change the I to E time too, because that's such a fast rate. At 1 to 2, they're having a hard time breathing it out at a rate of 30. So we're probably going to have to change that. You see how to change I time here? Yep. You see how much faster and harder that's going?
Yeah.
So go back down with that again, and you see where it reads out the I to E ratio there? So it's 1 to 5, which we said we do at that rate. So we don't want that. 1 to 3, okay, that's a little better. You can deal with 1 to 3. 1 to 3, 1 to 4.
Yeah.
I'm happy with that. You feel good about what we've done?
Yeah.
I know, you're not supposed to be an expert after, because that's a lot of information, and it's a lot of new
It's a whole
information.
lot, but
Yeah, but hopefully useful and at least a good starting point.
Yeah.
Take that sheet with you. If you want, when we leave, I'll write down some additional resources that you can look up that'll help. There's some good videos, some good blogs, and some good books. So the 2 books that I read were Vent Hero and Critical Vent Management for Critical Care Transporter. Anyway, it was the Flight Bridge version. Flight Bridge, you're familiar with Flight Bridge? It was the Flight Bridge Vent Management book. And then there's, along with the Vent Hero book, there's also a Vent Hero blog, which is an awesome blog. The same doctor that wrote the book, he does this blog, and it's all scenario-based. So he just gives you these scenarios, and he gives you the blood gases and what was wrong with the patient, and here's the numbers, and here's what it's yielding, and what would you do to fix that?
Yeah.
And then he talks you through exactly what he would do to fix it, and why, and how it would work, and he makes it very simple. It's real good. And then the last one is going to be a series of videos called MedCram, and I'll write all it down for you if you want. But that's a guy. He's a former ICU physician who's now a professor at a medical school.
Yeah.
And these are the videos that he puts up that give his students kind of a down and dirty layman approach to what he's already given them complicated versions for in class. Yeah. So it's like if you want to, like I said, acid-base balance, lab values, having good foundation in those makes all this stuff much easier. And he's got videos on all of it. From the oxyhemoglobin dissociation curve, a whole series on vent management, a whole series on acid-base balance, and then lab values. A lot of great resources there just within that one YouTube channel. But anyway, yeah, I'll give you that. And if you guys don't have any questions, that's all I've got for you.
Good.
Yeah, thanks a lot.
Thank you. Thank you.
Thank you, Pete. That's good. Good little class.